Hello and welcome. My name is Donna Cryer. I'm the founder and CEO of the Global Liver Institute, the largest patient advocacy organization for liver health. We have the honor of convening more than 200 stakeholder groups on the issue of liver health and all the ways that we can identify and solve problems that matter for patients and patient families, and frankly, keep people from becoming liver patients in the first place. And part of that is this fantastic series that I need to really just give a wonderful shout out to Sarah Maines, our liver cancers program director, because she has created this fantastically inclusive roundtable series for us that I hope are just the beginning of many conversations that we can have specifically to tailoring GLI's resources and programs to meet the needs of various communities. So today we are talking with experts in the LGBTQIA plus community. And I am so honored to be invited in to do so. And so I will be speaking with Jona, who is a physician assistant in primary and internal medicine with our friends at the Whitman-Walker Clinic right here in Washington, D.C. Leaders, pioneers, of course, in their field. We have Dr. Scout, who is executive director of the National LGBT Cancer Network in Providence, Rhode Island. As a New England girl in the fall, I'm a little jealous that I can't be there with you, but I'm happy to have you here. I have Jesse Powell, who is a physician assistant and director of the Minnesota Viral Hepatitis Echo at Hennepin Healthcare in Minneapolis, Minnesota. And anybody who knows me know I'm a huge fan, evangelist of Project Echo. And so I'm excited to finally have an opportunity to officially talk about Project Echo and the work. And we also have with us Dr. Shaylee Mangy, who is an oncologist at South Shore Hospital in Weymouth, Massachusetts. Welcome to you all. So I will start with you, Jesse. And I just want to say too, part of our diversity efforts has been diversifying the types of clinicians, the type of medical providers that we involve, not only in GLI Live or our roundtables, but in all of our activities. So I'm really excited to have PAs and nurse practitioners and advanced practice providers as part of this. You bring so much to the table that I can attest to as a liver patient. But can you just start us off with the particular concerns of the LGBTQ community regarding liver cancer and any particular drivers that we need to be focused on?
Sure. Well, thanks, Donna. Yeah, thanks for inviting me to this forum. It's great to be here and talking with everyone about this important topic. So I think, in the LGBT community, liver disease, probably, the main four things are the same as the general population, right? We see alcohol, Hep B, hepatitis C, and probably like NASH or non-alcoholic fatty liver disease is like the main drivers for, developing liver disease. I think globally, we think of hepatitis B being the reason why most people develop liver cancer. Here in the States, it's hepatitis C infection that's most prevalent, and then thus the big driver for liver cancer. In the US, in general, minorities tend to be diagnosed at higher rates for liver cancer, and also, unfortunately, present at much later with more disease burden and more significant disease, and tend to not be offered surgical options such as transplant or resection, as opposed to other groups like white counterparts in our community, which is very unfortunate. I think those trends are important as we think about the LGBTQIA plus community, because these trends are similar for them, I think, too. I don't think we have as much data to support that, to say it, but we think about these same groups, and someone that's LGBTQ could also be a part of one of these minorities, even putting even more disparity and less access to equal care in our current health system. So I think, hepatitis B and Hep C are probably the biggest things we think about in the LGBTQ community right now. We often think it's like, a sexual transmission, but also IV drug use is increasing amongst the group. So I think those two things are put people at higher rates. For Hep B in particular, I think we've been seeing a very large increase in infection amongst the LGBTQ community. And I've seen some places say up to 11% infection compared to like only I think it's 0.35% for the US population for Hep B. And I've seen some exposure rates for Hep B going up all the way to 81%. That doesn't mean they have chronic infection, but at some point they were exposed to it, may have cleared it on their own. So I think that's it's very frustrating with we talking about Hep B, right? Because we have a vaccine for this. This could be alleviated by by making sure people are vaccinated and is very preventable. So it's frustrating. We see low rates amongst men who have sex with men and Hep B vaccine uptake, but also in general in IV drug using population, and then like people with known chronic Hep C are low on their Hep B vaccines too, which is a little frustrating. So I think hepatitis C, similar rates. I think globally, I've seen numbers around 3.5% for the LGBT community, and then it goes up to around 6% or more if they have HIV co-infection. Here in the States, I've seen numbers between like 4 and 41% infection rate for hepatitis C in this community, as compared to about like 1.5% is like just the U.S. Prevalence rate for hepatitis C. Again, I think more importantly with this group, we think of Hep C not normally being a sexually transmitted disease, but amongst people that have multiple sex partners, in particular, like anal intercourse, may put them at higher risk for sexual transmission as well. So I think that's an important thing we need to remember when we're talking to people about hepatitis C infection. It's not just IV drug use that can be a problem here in this community.
Absolutely. There's so much stigma for all liver patients. And then to add, orientation and gender and trans status on top of that, I can envision that making it that much harder for people to seek care. That's not put together very well for any patient anyways. And the range though that you were giving of prevalence makes me think that there's a lot more research that we need to do to really have much more precise knowledge of what's going on across these different communities and the intersectionalities amongst identities that everyone has. Jona, you work in Whitman-Walker Clinic, and we've known for so long that many of the people infected with HIV also are co-infected with hepatitis C. And have higher rates of hepatitis B as well. So tell me what you're seeing in your clinical setting.
Yeah, I think it really comes down to the social determinants of health when we're thinking about why people who are LGBTQ plus have higher rates of disease, higher burdens. We know for a fact that there's higher rates of alcohol use, higher rates of cigarette smoking, higher rates of people being overweight or obese across that acronym, across these different queer communities. And so all of these different factors, these social determinants of health, certainly put people at higher risk of disease, then also make it difficult for their identities, and the discrimination they face makes it difficult for them to access care, which is why initiatives about increasing care access and making welcoming environments for queer people is really important. I think Jesse also mentioned some particular risk factors that are unique as well. I think another big thing is that drug use looks different in queer communities. The vast majority of our services are oriented around people who inject opioids and around really the patterns of substance use that in our cisgender heterosexual peers. The substance use, and this is what a lot of my work entails, is very different in queer communities. There's a lot more injection of meth. There's a lot different context. There's a lot more interlink between sexual practices and substance use itself. My specialty is specifically chemsex, and we see a lot of Hep C in that particular population. I do a lot of Hep C treatment at our clinic. We work from a comprehensive primary care model, so I do HIV PrEP as well as Hep C treatment. And a large portion, actually, of the people that I'm treating for Hep C acquired Hep C through slamming or injection meth use. And so I think when we're talking about the disparities between the communities, that's largely a population that's ignored. They are not seen in the drug rehabs that we see. They're not usually, it's not screened for appropriately. It's not what the questions we're asking are geared toward. And so I think that's another big risk factor. I think something else, some of the guidelines that are often also overlooked regarding this community is that, the CDC recommends annual Hep C screening for people who are sexually active with anal sex, specifically because of some of those practices. And I don't always see that done in patients coming from other clinics. And then I think obviously there's low rates of Hep B vaccination, but also low rates of Hep A vaccination. Anyone with any sort of anal sex practices should be vaccinated for Hep A. And there have been outbreaks in queer communities. And I think that's another area where if we're talking specifically about LGBTQ people, that's really important. But going forward, how do we mitigate these? Well, I'm not going to get too much into it. I don't want to jump the gun. But I think knowing about these different screening recommendations, really looking into what those specific risks are that are unique to LGBTQ people, and thinking about what harm reduction we can do. Remembering that there are people besides opioid users who need injection supplies and need to know that information. But at the end of the day, treatment as prevention is key.
I think that's so important. So many of all of the things that you said. I want to just emphasize a few of them. One is, as Jesse was saying, how preventable most liver cancers are. We have hepatitis B vaccination. We have cures for hepatitis C. We are, increasingly having ways to resolve fatty liver disease and NASH, even in advance of a specific treatment. And so we can really pull most people back from the brink of needing a transplant or liver cancer, but we're not really applying everything that we know. And the second point that I really want to underscore is the importance of patient engagement in the design of research and clinical practices, and diversifying the types of patients that are involved in these new practice, as I say, because they're still new for some, or not fully integrated. And so I think that as patients are involved in research planning and guidelines planning and all the different things that we train our GLI advanced advocacy advocates to be able to do, we need to make the door open a little bit more. It's not enough to just have one patient, to make sure that we have representation from all the different dimensions of people, so that we are getting these questions that somebody who comes from a straight cisgender community might not know to ask. So just because you have a patient on your committee doesn't mean that you have a full range of sort of patient and people experiences involved in the co-design process. So I'll make a commitment for our organization to do better, and I'll challenge others to do better as well. So Dr. Mengi, this did not just start as a new problem in 2022. Tell us about the sort of historical impacts and struggles that make access to transplantation and liver cancer harder than they need to be for people.
Thank you for the question. Unfortunately, in national databases, sexual orientation and gender identity are not measured. So LGBTQ plus individuals and their cancer incidence and prevalence remains invisible. What we do know in general is that LGBTQ plus people have an undue burden of cancer. Mm-hmm. And by that, I mean that sexual and gender minorities are more likely to have cancer than the general population, mm-hmm. and are more likely to do worse once cancer is detected. Mm-hmm. In addition, when you look across the cancer continuum, which is from screening to survivorship, or for some people, end of life, LGBTQ plus people with cancer and their families and their loved ones experience a lower quality of care than the general population. So if we bring this back to liver cancers, mm-hmm. LGBTQ plus people have increased risk factors for liver cancers, which we just discussed, including higher rates of alcohol abuse, higher rates of obesity among some sexual minority women, leading to NASH, and related to hepatitis C virus, which can be transmitted through sex. Studies show that gay men and bisexual men have higher risk of chronic liver disease, which can lead to hepatocellular carcinoma. And for many, this is due to increased risk of acquiring hepatitis C via sex. About 10% of new hepatitis A, 20% of all new hepatitis B, infections are among gay and bisexual men, and the overall prevalence of HPV, of hepatitis B and hepatitis C infections in trans people is higher than the general population. And I found at least one study that showed that lesbian and bi women and women who have sex with women have significantly higher rates of hepatitis B versus a control group in that particular study due to risk factors related to sex, multiple sexual partners, sex work, and also injected drug use. So, it's true sort of across the spectrum of LGBTQ plus identities that there can be an increased risk of having cirrhosis and therefore developing liver cancers. In addition, you have people presenting later with their cancers because they feel disconnected, unequal insurance rates, mistrust, screening for cancer that doesn't include LGBTQ populations. And so you probably will see, even though it's not documented, more liver mets and time of presentation of cancer. And so there is, a need to address liver disease in these populations. As far as liver transplant, the true incidence, we just talked about the true incidence, risk, and prevalence of liver cancers among sexual and gender minorities is not known. I can't give you a clear statistic because of the lack of sexual orientation and gender identity data. So similarly, the access to and barriers to liver transplants for sexual gender minority people is not known. It's not documented. I don't think there's a lot of literature on it. But implicit bias, particularly around support networks, plays a role. And I've seen it in bone marrow transplants and conversations about people who are LGBTQ and sort of in an end-of-life setting and a nursing thinking that they have nobody supporting them when they have an entire network of people supporting them. They're just not sitting at the bedside in the hospital, or they're not recognized when they're at the hospital sitting at the bedside. So the idea is that when you're evaluating a person for a liver transplant, judgments are made about someone's sobriety, about somebody's compliance, about whether the person's a citizen or not, about whether or not they have support networks. And in all of these areas, there's implicit biases that can have detrimental impacts for minorities, and including LGBTQ people. And so along these lines, there was a study last year by McClinton about access to liver transplant for minority populations. The study did not include sexual and gender minorities, at least they didn't report on that data. But it showed in the U.S. that Blacks and Hispanics are underrepresented on liver transplant lists and have an increased waitlist mortality rate. So while they're waiting for a transplant, they're more likely to pass away than whites. And additionally, after the transplant, Black patients in particular had a higher risk of post-transplant mortality. There's other data that shows socioeconomic factors at the time of transplant can impact long-term post-transplant wellness and survival. And LGBTQ populations, despite stereotypes about, people having money, it's not true. There's actually more people below the poverty line in LGBTQ plus populations. So while there's no data, there's every reason to think that disparities in the area of liver transplant access is very real for SGM people with chronic liver disease.
Again, the dearth of data is astounding and is a real barrier for us in our advocacy. You can't improve what you don't measure, and so that is just so striking to me as an opportunity for us to do better. So, Dr. Scout, are there opportunities for policy advances to support better care?
Well, there absolutely are. It's in some ways, it's kind of, we can only go up from here, think of it that way, right? If I think about the policy advances that have really stabilized healthcare more in the queer communities, the biggest one was really passing of the ACA, because as the first time in Section 1557, they established the fact that it included sexual and gender minorities as a class against which discrimination was prohibited. But here's the odd twist of that. That was only regulatory, it was not legislative, which meant it could change. And when the new president came in after Obama, who I will not name, he did change it and he took it away. So we actually are in this odd situation where I have never seen the LGBTQI organizations come together as much as we have. Whitman-Walker was one of the big lead organizations here too, over the last several months. Why? Because the feds were asking for open comments on whether or not LGBTQI non-discrimination protections should be reinstated. So it's slightly ridiculous. And we, between all of us, we rallied 16,000 comments on this point, obviously saying, yes, they need to be reinstated. But it gives you a sense of what we're dealing with right now. We're fighting for the ability to have non-discrimination protections, much less the idea of, tackling, like the implicit bias that Shale was talking about, or, tackling the fact of the fact that we're not usually included in, guidelines documents or anything that's just one micro step more complicated than that. So there's a lot of room for improvement in a lot of different areas, well beyond non-discrimination. We do see, as you were pointing out, and many people are bringing up, this lack of data collection is just such a huge issue. We are happy that the National Academies of Sciences, Engineering, and Medicine, after a year-plus wait, came out with the most definitive document so far on why data collection is important and even how to specifically do it with suggested measures. Not perfect, but best available according to the tested science thus far. And so what we're seeing are some things as a result of that that are very promising. Like, for example, at National Cancer Institute, which is the biggest part of NIH, so it's a big fish in that pond. Thus far, they obviously designate the best cancer centers in the country. There's, over 60 of them that do patient care. And we were even looking at how did those NCI designated cancer centers do with having any LGBTQI welcoming materials in Pride Month. And we were really excited to see how, like Mayo Clinic lit up their whole building in rainbow colors, things like that, right? We were less excited to see about a third of them had absolutely nothing, nothing. And this is for the best in class cancer centers. But NCI has taken that NASM report, and as a result has given small bits of funding out to cancer centers to have them start to collect the data about our communities. And of course, you don't collect data until you establish welcoming first, right? So the first thing you got to kind of say you're safe here before you want us to disclose anything vulnerable, right? So that push for these cancer centers, I'm not sure how many were awarded. We're working with 7 that I know got it. But that means that at least 7 of these NCI designated cancer centers are right now in a year-long effort to be like, how are we welcoming? How do we fall short? Are our staff trained? And then once we get that welcoming into place, how can we make sure we actually put those data together? Because the interesting thing about a lot of these data gaps we're talking about here, some are research-based, but many of them related to cancer are because of no information in the registries. And that comes from health records. So the truth is, it seems kind of odd, but it's going to be fixed by like the next time you go into the doctor. And if you have a broken elbow, they still say, are you LGBTQI?
Right.
It may not seem related to your elbow, but it actually is related to long-term monitoring of surveillance issues. So we actually think one of the places where we're seeing a lot of change these days is, are the providers asking these questions, particularly cancer providers? And it is an area where anybody can speak up anytime you see, or in a provider's office. And if you see that they're skipping those questions, then they're part of further hiding this discrimination, hiding the disparity here, and impairing us from ever, as you say, seeing it, measuring it, and then finally fixing it.
Right. I think that is so important to go just beyond, Pride Month virtue signaling. As I talk about, Black history things in February, I'm like, I'm Black all year long. And so people are queer all year long. And so these programs, cannot be just, for show and limited to some, calendar or flag exploration. They really have to be built into the systems of care and the way that the organizations do business. So I think embedding in the EHRs, embedding in the patient information and access, it's really important to what it means to be, a patient-centered institution. So I think that's a very important, point. As we're raising awareness, how are we raising, awareness
Make
all
it
the
routine
way
instead of exceptional, right?
Yes, exactly. So I want to, I want to just talk about everything because you are firing me up. So Jona, I want to go back to you as you were talking about what good screening looks like. And so I think as we go through this sort of next round, I want people to feel empowered now that we know that there's a problem, about like things that they can do. So how does Whitman-Walker make people feel welcome? And what are some of the, changes in guidelines and screening that you all instituted, and how you do care differently that, results in healthier people?
Yeah, so I think I'll start by talking about this space first, and that's
Mhm.
putting a lot of very visible, like, sort of signs that this is a safe space for
Mhm.
LGBTQ people. That can be like pronoun pins, that can be little pride flags, that can be
Mhm.
informational posters. I'm thinking about
Mhm.
also what's in your lobby. Patients spend a lot of time in that lobby.
Mhm.
What reading materials you have, and are they
Mhm.
seen? Are they visible in that lobby? When they look at the posters in your office, can they see themselves? And that goes for
Right.
both people of color. It goes for a lot of other identities too. People
Mhm.
want to be able to see themselves in your staff and in your lobby. And
Right.
I'll segue into also that really applies to hiring too. The more you can think about your hiring practices in terms of
Mhm.
hiring people of color, hiring LGBTQ people, I think that's really important. And we've certainly made that a priority at Whitman-Walker. We
Mhm.
really try to have a staff that is similar to the communities that we serve.
Mhm.
In terms of screenings and practices, I think that what we don't want to do is pathologize LGBTQ people. So I think it's less about associating these risk factors with the person, and
Mhm.
more thinking about screening for behaviors.
Mhm.
There are people outside of that acronym who do have anal sex practices, and they therefore need a hepatitis A
Mhm.
vaccine. So really just thinking about being really forward about your liver disease
Mhm.
screening, knowing what the different behaviors are and risk factors are, doing good screening work, and making sure that we're getting in those preventative tools. I think that in general in the US, one of our big failures is preventative medicine. We
Mhm.
really concentrate a lot on emergency care. Our funds go into emergency and specialty care, where really actually the majority of funding should be going towards preventative medicine.
Mhm.
And that's what lowers healthcare costs. So really sort of shifting the gear, I think the more that we can reach our preventative providers on doing these broad and good stroke screeners, the better. And
Mhm.
making sure that those people are trained and feel at least somewhat culturally competent in working with LGBTQ communities, so that they're asking the right questions, they're not offending people, and they
Mhm.
can LGBTQ people can get the appropriate screenings in an environment where they feel safe.
I think that's such a great point about focusing on behaviors, because there's so many assumptions about who has liver disease that a lot of people are missed, and I consistently say, if you have a liver, which is everyone, then you are at risk for a liver disease and should have a screening for, or multiple different types of screenings for liver diseases. Because I remember standing in line at CVS, where I'm often found, and I was telling someone about, I have a liver transplant. I was waiting for my transplant meds, and she was saying, I think she had sort of made her peace with, okay, I look okay, but I somehow have a liver disease. But she was saying, well, at least children don't get them. And I was like, oh wait, not so fast. And so what I started talking about, mother to child transmission and hepatitis B and children with fatty liver disease and genetic disease like biliary atresia. And I'm like, anybody could have a liver disease, from a pregnant person to an infant to a grandparent. And I think that's the point where we need to get to sort of a normative universality of understanding and screening and care. So Jesse, how does Project Echo help scale excellent care, in liver disease, where not everybody has, the resources and the team that we see in Washington, D.C. or in, Minneapolis? And so how does Project Echo help scale care so more people get the best practices?
Yeah, I mean, I think ECHO really empowers our community providers to take on some of these disease states that they may not have felt comfortable in the past. It started out as a way to improve hepatitis C treatment. Dr. Aurora down in the University of New Mexico is a gastroenterologist who was having people wait 5 months just to get their hepatitis C treated. And Jona, I don't know if anyone else on the panel is treating Hep C, but it's like the easiest thing in the world to do. Like after you do it a couple of times, it's like, I fear trying to manage diabetes, like Hep C, give it to me any day. This is like so easy. So I think just getting that knowledge that some of these things are simple and easy to do. You just need a little guidance and a little education and a little support around you. Really makes it easy for people to branch out and start effectively caring for people with Hep C or Hepatitis B. What I really love about ECHO is it's gone beyond just like this Hep C to like all kinds of different things. And we're seeing like we have a diversity ECHO in our for injection drug use and trying to like decrease disparities and like stigma and stuff around that. So I think there's a great space for LGBTQ and like viral hepatitis, liver disease, echoes and things to help promote, better screening, appropriate screening, appropriate treatment, like being sensitive, teaching people how to be culturally competent when in dealing with people of different groups. So I think that's an exciting avenue, and I hope someone will pick it up, or maybe I will if I can find the time.
Well, we'll absolutely help with that. I think one of the things that's so important for me, and I think is a relevant part of this conversation, is making sure that these welcoming environments and best practices in care aren't just restricted to metropolitan areas, but that there people in rural communities and all types and sizes of communities that need this care and consideration, and they probably need provider training even more. And so I think it's very important to, particularly as we're, talking with the White House about hepatitis C elimination, that we're reaching out to all communities and making sure that they have the resources, including the training and the people, to be able to reach everyone who needs care. So I think that's a really important part of things.
And the beautiful thing about ECHO is all you need is a webcam, a laptop. We
all have those now.
And that's maybe one great thing out of COVID. We've all learned how to use Zoom, and that's the platform we were using for ECHO for many years. And so everyone's become accustomed to this way of communicating and meeting and learning. So it doesn't take much infrastructure. You don't need a whole lot around you to link yourself into a big community of people that are wanting to learn the same things that you are, and getting you attached to experts in that particular field or space. So it's a great avenue to learn more and engage with your colleagues and become competent in whatever it is that you're choosing to go after.
I think that's fantastic, and we'll make sure to put that in the show notes and wherever this appears. Chael, I'd love to talk more about research needs globally. We go from rural communities in the U.S. To global communities who are impacted by liver diseases, liver cancer, and may have even more stigma or more barriers to getting the care that they need. Can you tell us about that?
Yeah, I think that the sexual orientation, gender identity data collection issue internationally is even more difficult. And what we do know, here we've been talking about gaps in data. What we do know is that if someone in the U.S. Lives in a state that lacks protections from discrimination, so from gender identity or sexual orientation or housing or job protections are lacking, people who live in those states, their mental and physical health is worse. We see this on a rise in youth. With these anti-trans laws, we're seeing an upsurge in suicide. We see direct impacts. And so internationally, there's 69 countries that currently criminalize consensual same-sex sex, with jail time being a real consequence in many countries, and with 11 countries where the death penalty is on the table, and 6 countries that actively are using the death penalty for private, consensual, same-sex sexual activity. So when we have this whole gamut of different spaces internationally, it becomes very complicated. The social rejection, the need to be closeted, the lack of protections for discrimination in housing and jobs. We know this undermines the health and well-being of LGBTQ people. And then on top of it, we have direct, legal issues that are directly harming mental and physical health, adding to stress. And yet these cancer risk factors remain, because when you push people into a closet and you can't talk about safe sex, these things are still happening, and alcohol is still happening if it's accessible in that country. The minority stress and how it manifests is still happening, but we don't know what the actual cancer burden is. So the solutions for an international scheme are hard to picture. I know American Society of Clinical Oncology tends to try to lead in a lot of spaces, but while they've done a global curriculum for oncology, for people in oncology training, coupled with ESMO, the European Society of Medical Organizations, I'm not sure what the O stands for.
There's a lot of acronyms, always in healthcare. A lot of acronyms.
So the thing is, like, there's a global education. I got to work on it, but there was backlash from Eastern European countries. There was not much understanding how much of that part of the curriculum was going to be picked up by oncology training programs in other countries, and there's not really an understanding of whether it's safe. I know providers in trans health and HIV who've gone to Jamaica, for example, and had to advertise that they were doing a health conference about something else, and then in very hidden sort of safe places do these sorts of conferences. And there had to be safe providers who could, say that this sort of education was going on. So the thing that I think about the most when I think internationally, unfortunately, is not just about all these challenges, but about safety. We don't want to be responsible for telling somebody something's important to have in a record, and then that being used to prosecute somebody.
Right.
And we do have a history in this country where maybe we have some understanding of that, although it wasn't thought to be medically relevant for a lot of the time, before 1969. And so I don't know how much it was in the chart. I don't think people asked. I think we still deal with some of those biases. But to really think about, maybe as a nonprofit that has an international reach, if you have these neutral platforms to be able to talk about the education and then somebody can access it. I don't know if it's like North Korea and someone, or certain countries where you search something on the web and it's either not accessible, it's a dead link, or it puts you on, or somebody knows that you searched it, right? So I don't know what's safe or not, but to have it accessible by country, to have a database maybe of safe providers, to have education and agreed upon language to keep your patients safe. There are interesting challenges internationally, not specific to cancer and liver cancer, but I think that nonprofits like yours can think about these questions when they're doing
Absolutely. This is why we're having these roundtables, to identify issues that might not otherwise be apparent or at the top or linked together. I think the safety of both the provider and the patient in these contexts, and just sort of seeking life-saving care, is not something that most people think about. And so I think it's important that we do.
And I would just add that,
Go ahead,
unfortunately,
please.
with the current backlashes for cis and trans women and right to bodily autonomy and medical decision making and the privacy between the patient and the provider is under attack, it is a U.S. issue. We do see providers being attacked for doing trans health, as we have seen for abortion for many years. So it's just, unfortunately, an issue in the world right now.
Well, if it's hard to get a cake, I mean, then it's gonna be some barriers to get care and be recognized as a person. I did wake up this morning listening to the news and hearing about various personhood legislation, and I was like, "Aren't I a person too?" I know. Aren't we all people, shouldn't I have some right to my body? I'm an attorney by training, and I am a constitutional scholar, and so my team has had the whole lecture on privacy and personal protections that are at risk at this point. And so I do think that it puts our health and humanity at risk at this point, far beyond the issues of liver cancer and liver transplant. But we do need to take them on. So Scout, Dr. Scout, I want to come to you about issues of financial toxicity in cancer. Are there additional, as we think through all the different barriers and burdens for patients receiving the type of cancer care that they need? We've already heard about their networks and caregiver networks not perhaps being respected. Are there additional costs that certain patients and their families or and friends incur in trying to achieve cancer care? Do they have to travel more? Just walk us through what some of the financial burdens might be.
Yeah, and maybe I'll expand that to kind of just all across the spectrum, some of the barriers. So, as Jona was talking about, we are less likely to get that appropriate care in the first place. If we're long-term HIV survivors, we're less likely to get the intervention. I look at NIH right now, it says about 21% of long-term HIV survivors have Hep C. So we're less likely to get those routine interventions to try and clear the things, so we end up being at greater risk in the first place, right? We also are less likely to have a routine healthcare provider or a medical home. And that's probably one of the biggest things that the provider world needs to understand. Why? Because so many of us have either directly experienced trauma at the hands of our medical providers. Like, as I realized the first time I went for a cancer screening, it took me 2 days to heal because the doctors, when they found out I was queer, were not remotely gentle. So we've either experienced this ourselves, and this is particularly among the trans community. This is particularly among trans people of color, particularly among trans women of color. And also, just another note, our population is actually much more racially diverse than the general population of the United States. 42% of us identify as racial and ethnic minorities versus 24% of the general population. So this intersectionality is even much more of an issue. So we are less likely to have that medical home because there's been this history of trauma. And that means that we're, of course, less likely to get the routine screenings, to even get to the point where we are noticing anything abnormal. And then when we do get those implicit bias issues, once those, we start to have something that goes wrong, we have a lot of people talked about, if they report, pain in their anus, the provider doesn't want to deal with it because they're like, oh, I presume it has to do with gay sex. So, that kind of dismissiveness, and also that kind of judgment about how lifestyle or, whatever they're presuming might actually play into health outcomes. So you end up with those presumptions, those implicit biases. And all those things mean that, yeah, we're absolutely more likely to show up later. But then even when we do show up, as you point out, it's not always easy for us because we're trying to find presumably a provider where being queer is not an obstacle to us getting care. We know from patient-centered care that if you have two providers that are getting the exact same treatment, but one of them actually clicks with you more, you're going to get healthier. So this idea of how we're respected in care is actually much more important than even our communities realize. But we do know we need to get away from the toxic providers, right? Which sometimes means that we do, if we've got these stories from our cancer survivor surveys, where people are like, the only hospital in town was a Saint blankety blank. And I did not feel comfortable going there because by the time I add me, my support team of 3 exes, the one sibling who still talks to me, and 2 friends, and then of course all cancer patients are kind of frequent flyers in the medical care system. So your main provider may be good, but what about all those sub providers? One of my friends, trans woman, talks about how she was worried that she was going to die in the shower because where it fell apart was her home health aide. She was too weak from chemo to get out of the shower, but the home health aide didn't want to deal with a naked trans woman. And so as she's like weekly calling for assistance to get out, she is being absolutely ignored. So, again, you may have to travel farther to find that one welcoming provider. But then when you expand it to the legion of people you're suddenly going to see, it really starts to create all these potential areas where it can fall apart. So I think one of the big things that I really want the provider community to know is treating everybody the same is absolutely failing for any
Mhm.
population that's had systematic different treatment over our history.
Mhm.
We have had social exclusion. One of the survivors that we have speak pretty frequently talks about the doctor who was very clear. It's like, I don't want to treat you because it's against my religion. When we have that kind of history, that means that we need some sign from you that it's welcoming. And if we're not getting that sign, and that sign can be like, as Jona was talking about, signs in the waiting room, things on your website, pronoun buttons on your lanyard, on your
Mhm.
Zoom, in your introduction. Hi, my name is Dr. Scout. My pronouns are he, they. Doesn't mean you're forcing anybody to disclose theirs. But for someone who's had systematic discrimination based upon it,
Mhm.
you're saying, I acknowledge that there's been a problem. I don't want to be a part of perpetuating it. So for all of the providers out there, show us we're safe first. Because if you're not showing us you're safe, you're part of our continued disparities.
That is so powerful. I just, first of all,
I
my
do want
heart
to
was
say
hurt,
something.
but
You
please,
know,
please go ahead.
there is something where people can put a pronoun sticker or put a rainbow sticker and they have no idea how to take care of LGBTQ people,
Mhm.
and they have no idea and they have not dealt with their implicit biases. I think that, there's a provider database that Glam was putting out with Sarah and Teagan Foundation that, at least there'll be a designation that this person has sought some level of education. But
Mhm.
I have always been wary, just as someone who's been a provider and gone through hospitals and done all of these things and seen people have rainbow stickers, and I thought they were like a great person to mentor me, and I walk up to them and they know nothing.
Mhm.
I think that there has to be something to back it up and not just using rainbows as advertising during Pride Month.
Yeah, not
I,
performative. And may I
yeah,
just say one thing here too? We right
yeah.
now have a 5-part training for anybody who's in the health system to get better cultural competency, safety, humility related to our populations. It's absolutely free, offers full CEs,
Mhm.
at least free through the end of the year. So it's called Welcoming Spaces. Seek out those types of things because Shayla's absolutely right. You can't just have performative welcome. You actually
Mhm.
have to be aiming for true safety.
I think that's so important. And I'll just, before I'll go to Yona, I'll go to you next. But most people know I'm on the board of a hospital. And since that time, and so I have a board badge and everything like that. But I, as a patient, I'm frequently seeking care. And so I put the board badge in my purse or my pocket or whatever. And I just want to see how people treat me. And I just want to be able to see how they treat other patients in the waiting room or the surgical suite. And it's very informative. And so sometimes there are, I'm very proud of the hospital but there are times when I make note and I bring it up to a chief of nursing or someone, or raise the issue in a board meeting. And there have been times when they have to sort of type in and they realize there is like an access thing on my medical record, and I can see it in their face. I'm like, oh, oops. Like I bet you wish you had treated me nice. like just like as any person coming into the institution has a right to expect, not special treatment, but just maybe you wouldn't have been snippy with the person who was fasting and who was whatever, or who questioned taking a pregnancy test, or or anything like that. Maybe you would have treated that person better. Sometimes I'm trying to advocate for someone, a patient I just see, helping them fill out a form or getting them extra time. And so I think it's just very important to embed those things in every person that is part of that health system, from the receptionist to the security guard giving tours to the physician, because all of those are part of the patient experience. And it leads me to want to ask if anybody wants to speak about trauma-informed care. because I know that's very important to many of my friends, across orientations and gender, but particularly for my friends from this community, having providers who have who know how to provide trauma-informed care is really important. Does anybody want to speak to that, Jona?
I can speak to that, certainly. So this is really important, especially with a lot of the communities that we serve. Not only do we serve people with a lot of intersectional identities.
Mm-hmm.
I work at both of our sites. For those of you who are not familiar with Whitman-Walker, our Southeast site, which I spend about 50% of my time in, we serve a large unhoused population and really a
Mm-hmm.
community of color. And a lot of communities that have experienced trauma. We also serve as as a FQHC, as a safety net provider, a lot of people who are undocumented and have dealt with a lot of trauma related to migrancy. So I think trauma-informed care is really important. It looks different ways depending what your practice is, but I definitely think it's essential. But again, I really like this other term as well called healing-centered management. And what that's about is that the trauma-informed care is making sure that you're getting consent for every piece of what you're doing, that you're narrating what you're doing, that for people that have experienced trauma, they know what's going to happen. You're giving them accommodations. You're not always just pushing whatever your agenda is, but you're really listening to them and seeing what they can tolerate that day. But I think what's nice about this idea of healing-centered management, which we especially use in substance care, is this idea is that people who have undergone trauma are very resilient people, and celebrating them for having been through that trauma and not just looking at these people as victims that we have to tiptoe around, celebrating that they've had some resiliency as well. So in terms of what that looks like in primary care, especially in sensitive exams, it means, again, giving them options, checking in with the patients, letting them know each piece of what's going to happen, doing a thorough pre-explainer, things like that. And there's a lot of other pieces too. I mean, language concordant care is really important to this as well. Again, if we're talking about some of our people who might be migrants, making sure that they especially understand what's happening, because a lot of times things just sort of happen to them and they're not fully in the loop. I think that's really important as well. And then again, as much as I can, I would say that don't let trauma-informed care let you treat people like victims, because a lot of these people, it's all about restoring their agency. And I think that's really important too, is giving the focus should be on giving agency back to the person, recognizing that each person is the leader of their own healthcare team. And that regardless of whether or not you think they need that screening at that time, what really comes first is their ability to participate actively in that screening or in that healthcare. And applying this to liver disease, thinking about things like their liver ultrasounds, whether or not they have to travel, things like that. Thinking about what they can tolerate and what is accessible to them at a given time.
I think that's fantastic, and I think that you're absolutely right. So many people have, as I talk to patients who work with us, I'm like, you've already survived so much. Like this is easy. Like talking to Congress or something, like that's easy. You've survived like a transplant and like homelessness and 1,000 different things. Like speaking to your member of Congress, like that's the least of it. You're a warrior. So we can do this. We've been built to do hard things and have overcome. And so I think dealing from a strength-based or an asset-based position, a resiliency position, whether you're dealing with individuals or communities, is just so much more powerful and so much more enduring than doing something another way. So we have talked about so much, and I want to make sure that we have raised all the issues. I know all the issues, raised as many of the issues as possible. So let me go around, as we close this out. We have an increasingly wide audience, for which I am grateful, of primary care physicians, of people in public health. And so to whatever audience you'd like to speak to, I'd love to give each of you an opportunity to just have, what's the most important takeaway, or what's the action you want people to do most when they, after they view this roundtable. So maybe Dr. Scout, I'll start with you.
Sure. I really think, another thing that we got related to our big cancer survivor survey, and we're just doing the multivariate analysis on it now, is that one finding came out the largest, and that was that you have a much higher potential, almost 7-fold higher potential for rating your care as being excellent if you see one thing. And that's if you would rate the actual office as very welcoming to start.
Mhm.
So I really would like us to think about wherever we are in this continuum related to healthcare. If you're a direct provider, it's easy how you can make change. But if you're GLI, what do you have on your website that's talking
Mhm.
about this population? Are you taking things, and rebranding them from us, which, members can do for free? Are you creating new materials? I hope, because we have such a paucity of information out there. Or if you are a patient, are you asking why there's not more welcoming
Mhm.
information? And are you asking if your providers have had training with this population? So
Mhm.
we have such an easy way to increase people's potential care experience. And that's to really lean in and have the expectation that, right now I'm more likely to see all races, genders, sexualities are welcome sign in my local bakery than I am in my local doctor's office.
Mhm.
That needs to change. Let's shift the expectation. And if everybody can be part of just asking, why isn't this happening a little bit more in whatever
Mhm.
rooms you have access to, I think that could be immensely powerful.
I love that. I appreciate that. And that's one of the reasons why when we started our Center for Liver Health Equity, I think people's expectations that as a Black woman, I would be focused or, exclusively on issues in the African American community, of which I love, and I'm centered. But it was really important to me that we be more than that, in that we include this community specifically, as well as cross intersections with all of our different vulnerable populations together. But I wanted to do this specific call out if we were going to do this with intention. Got me choked up. Shale, what is the one thing that you'd want people to take away from today?
So I'm gonna just do a couple different levels. So for leaders, hospital leaders, administrators, to really make room for SOGI data collection, for sexual orientation and gender identity data collection, and to promote a welcoming culture. For funders, really thinking about research to qualify best practices, but also to really fund more implementation studies so that we can bolster screening and prevention of liver cancer and liver disease. And for staff and providers to fill in social determinants of health at the level of the clinical encounter, and to use that information when they're taking care of somebody in this trauma-informed way that we just discussed, and really to seek whatever education you need to address your implicit biases, because they're really subverting access to quality care for LGBTQ plus people.
Thank you.
And,
Jesse
and for
Powell.
that
Oh,
last
go
point,
ahead.
like what I do
Yeah.
is I kind of I don't expect myself to be free of implicit bias.
No.
What I do is tend to know myself as much as I can, but also to be aware of the data. So be aware of data where people of color are not offered clinical trial access. So they're not just, nobody talks to them about the clinical trial, right? And so that seems to be the biggest reason for the differences in rates. And so I make a point of, when I'm seeing a person of color, of double checking myself. Did I talk about a clinical trial? So the thing is, there's a lot of soul searching to do about LGBTQ people and how people feel about them.
Right.
And that should be done, but also knowing the data and checking yourself, I think, can be done.
Right. I think we are all privileged to have opportunities to grow. So I think this is just another opportunity. Jesse, one takeaway.
Yeah, I'll look at it from maybe more like the clinical aspect of hepatitis B and viral hepatitis and improving screening and, linkage to care beyond that. I think one thing I like to bring up when I talk about Hep B is almost 2/3 of people don't even know they have it. We're talking about poor vaccine uptake. We don't screen for this. And then communities like this are even at higher risk for non-screening. So we need to really focus on just primary education for providers that everyone needs screening. People with ongoing risk factors for exposure need repeat screening at least once a year. And then, I think, having education on how to work with LGBTQ is very important. I think that, we need to meet people in the community more often than wait for them to show up in our specialty clinic. So I love seeing, I have a viral hepatitis clinic that I've embedded in our positive care clinic, which is our HIV clinic. I take my liver disease practice to them. You know what I mean? I would love to see more people, more providers doing these kinds of things rather than waiting for the referral to show up in their place. So I think those are really important. We need to be out there as a community, as a provider. We need to be
Absolutely.
out there.
It was remarked that it was 1960 at UCLA that the first gender identity clinic in the US opened up. And now we have all of you and all of your work. And Jona, what should we be doing, now and in the future to advance all of these issues?
Yeah, I think I'm going to split it into two things. I think in terms of the future, I think that Shale and others said wonderful things about the way that research has to go. I really want to emphasize what Shale said about implementation research. And I'd also argue for the idea of translational research. I think there's a lot of prevalence data. I think there's a lot of correlation data, especially between marginalized identities and health factors and poor health outcomes. But what there isn't a lot is a lot of research and data that's being used to actually better our community to lead to better health outcomes. And so that's what I would say for the future. What I want to see is not research for research's sake, but research that really involves a community advisory board of LGBTQ people, of people of color, that is really community-based research and research that's going to actually, at the end of it, have a positive impact on our community. And, in terms of the future as well, I would also make the argument in closing that I think all medical providers need to have an understanding of the social determinants of health. I know this is a contentious issue, but I think that's really how we move forward, how people start to understand that it's not being a person of color, it's not being LGBTQ that puts you at higher risk for liver disease. It is those experiences of oppression and marginalization that lead to poorer health outcomes. So I think those two things, the translational research and then also greater understanding of the social determinants of health for medical providers, regardless of specialty, including our hepatologists, et cetera. That's how we move forward.
I think those are wise words. And I think that this is really helpful for us to set a clear agenda at the Global Liver Institute for how we can be great allies and advocates to make sure that we are making good on our mission to have equitable care for everyone. So thank you all today. Thank you for what you all do every day for people. And I'm so honored that you would have this conversation with us today. Be well.
Thank you.
Thank you.